Hello everyone, welcome back. Today Kibby and I are going to talk about a disorder that 12.5% of United States adults will experience in their lifetime, and that is phobias. Phobias is a pretty cool topic because there are a lot of odd ones out there, but the treatment is, I would say, relatively streamlined, effective, same treatment for pretty much all phobias, and so there's actually a lot of hope out there. Phobias is one of the most treatable conditions there are, right, Kibby?
Yeah. Behavior therapies are really, really useful for them. So, if you have a phobia, there's hope.
So, a phobia is an intense or irrational response or fear to something that is not actually life-threatening. And you most often hear about this in terms of, let's say, snakes or spiders or flying or heights. Now, some of those, of course, can be life-threatening. And in fact, there's a theory that we most commonly will have phobias for things that kind of make sense from a biological perspective, because when we were out on the savannah or in the woods, there were spiders that could kill us and snakes that could kill us. But now, this fear is more irrational because it isn't very often that we are in contact with these things. And so you might hear a lot of people say, oh yeah, I have a spider phobia. I hate spiders. But what you need to know is that in order to qualify for a phobia, this has to be really disrupting your life in some way. So there has to be this genuine impairment. Kibby, what might that look like for a spider phobia?
Yeah, I think you're making a really good point because a lot of people don't like these things, right? Like, whenever we assess phobias and ask, is there anything you're afraid of, like flying, seeing blood, insects, needles, or blood, a lot of people say yes. But if it's something that's just, very uncomfortable to be around or scary, that's not necessarily a phobia. A phobia is, it's the way I ask the question is, okay, but if you don't like spiders. I don't like spiders either. If a spider was in your house and you had to go in there, could you do it? Or would you have to leave the house immediately? And then the follow-up question too is, has this affected your life in any way? Like, do you tend to avoid situations because you're afraid of encountering a spider? So what this looks like is someone who can't possibly live where, near the woods, or can't go through a park, or can't take their kids to the playground if they're afraid of spiders. Or if they're afraid of flying, a lot of people will say, yeah, I just find jobs and, have all my activities and within driving distance. And now I could just avoid flying entirely, which makes it kind of tricky to assess because a lot of people just shape their whole lives around it. So when you say, does it interfere with your life? They'll say no. But, if you really think to yourself if you really mold your life around this phobia, this fear of, and trying to avoid something specific, that might be a sign of phobia.
Yeah, I think flying is a good one to point this out. I mean, because a lot of people would rather take a 10-hour drive than a 1-hour flight, and it has nothing to do with finances. Or they've just stopped going internationally. And they might say it's something to do with finances, or they're just happier being here. But people with phobias can sort of tell themselves stories about why they do things or don't do things, when in reality there's this fear that they're trying to avoid. They might be unable to go on an airplane without Xanax, and that's actually a pretty big deal, right? Because Xanax is a heavy-duty medication. What if you get to the airport and realize you left it at home? So this, while some people with phobias may think that it's not a big deal, that can be because they've just shaped their lives around it.
That's a really good point, Jacqueline. I think we've talked about this when we've talked about panic disorder or other kind of anxiety disorders. Some people will have safety behaviors around it, right? So if safety behavior is something that people do in order to keep themselves safe from this perceived threat, right? So if Xanax, if you need Xanax to get on a plane, that would be a safety behavior because in their minds, they think, okay, they believe that this is going to be dangerous no matter what, but they're safe if they do X, Y, Z. right? So it's still considered a phobia because they're still avoiding contact with this threat.
Yeah, and the thing about safety behaviors that's important to remember, I mean, if you have to wear the same pair of lucky socks in order to get on a flight, and that might be working for you fairly well, and it might not be that big of a deal, but at the end of the day, what you're telling yourself over and over again is, it's the socks that get me through this flight. It's not me. I'm not able to handle this. And so it, over time, kind of whittles down your agency, your ability to handle distress and negative experiences. And so that's why safety behaviors are one thing we would work on in therapy.
Yeah, and I get, even thinking about this, even when we're talking about it right now, I'm like, well, I'm afraid of spiders. Mm-hmm. And I know some spiders are dangerous, right? Like I know they are. But when we say irrational fear of something, it's not a judgment. It's basically a fear of something that is not proportional to the actual likelihood of threat. So if I act like every single spider is going to kill me, that's not based on the facts, right? That's not based on the actual likelihood that I will die from a spider. Yeah, there are spiders that are poisonous and are dangerous. But if I'm reacting to every single one like they're poisonous, that's what the phobia is all about. And we know that phobias they develop kind of like any other anxiety disorder. I know David Barlow in Boston University, they're the big champions of understanding anxiety disorders and things like that. But it's basically like if you have associated fear with a threat, right? Like a spider. I'm coming this from my own perspective because when I was a kid, I was like 12 years old. I was reading a book in bed and I felt a tickle on my neck, and I looked down and there was a daddy long leg the size of my hand crawling on my face. So no. I screamed, and I flipped it off. And then ever since then, I've been terrified of spiders. I wouldn't say I have a full phobia because I'm living in North Carolina where there's like spiders aplenty. But this is exactly how it happens. You have either, a bad experience with something, like you're bitten by a dog, or you're on a scary plane flight, or you heard about a plane crash. You associate that thing with danger. And as you said, with biological preparedness theory, things that are actually dangerous, you'll kind of pick up on that association more quickly, right? We'll like attach that fear to spiders faster than like my lamp. But then we overgeneralize that learning, right? Like, oh, that one daddy long leg on my face was terrifying. So now I'm terrified of all spiders, and now all things that kind of look like a spider and all hints of a spider, right? So I'm going from that one scary moment to like kind of associating my fear with like more than just that one. Mm-hmm. That's how phobias happen.
I have just such an urge to like find a spider and capture it and then just kind of like put it on your head.
Oh yeah? Yeah, well, when I was in my first psychology class, just like a budding student getting excited about this field, and I was sitting in a lecture hall and we were learning about phobias. My friend, Alex Greer, I'm going to say his name on air, Alex Greer sitting next to me, and they had a big picture of a spider on the screen, and he knew that I was afraid of him. So he tickled the underside of my leg, and so I almost screamed in front of a whole lecture hall of people. So shout out to you. Thanks a lot.
Like, I know how much you're not supposed to do that, because misophonia, there's sort of a similar... it's a baby similar process going on. I mean, it's not quite fear of sounds, but so many people, when they hear that their friends are misophonic, they just want to like chew in their face, and that's a bad thing to do.
Yeah.
But it doesn't stop me from wanting to put a spider on your head. Anywho, another phobia you've said you have is blood and needle phobia.
Yeah, blood and needle phobia is a really interesting one, because now phobias can be interesting because it's all these weird little different niches and new kinds of phobias coming up all the time. But blood and needle phobia is really unique in the sense that all other phobias are fear responses, right? Like you have this intense fight or flight response. So your sympathetic nervous system is supposed to go up, right? Your heart increases, your muscles tense up because you're going to run away from this threat. But it's called blood injury and injection phobia, officially. It's the only phobia that we know of in which your blood pressure goes down. So you have a vasovagal response. So your blood pressure drops really quickly. And that's because it's super interesting biologically. It's your body is saying, oh no, I think I'm bleeding. I think I have an injury. So I'm going to conserve my blood. So I'm going to drop my blood pressure down so it doesn't pump as much out. So, and it's actually really inheritable. So it's a genetic component. And I know that because my dad had it. And my dad was this guy who was just, he was like, I'm afraid of nothing. I'm a tough guy. He was a big tough guy, a big alpha male kind of personality. But he had this phobia. And a story that my stepmom tells me all the time is she was giving birth. She was about to give birth to my brother. And they're in the hospital. She's sitting on the doctor's table and my dad's in front of her. And she's going to get the epidural shot, right? And she knows that he is not good with needles and blood. So she's like, can you get out? He's like, oh, I'm fine. Don't worry about it. But they take out this like long, scary needle. And he has his hands on her shoulder to steady her and calm her down. But as the needle is going into her back, she looks up and sees that his eyes are fluttering and he starts to like wobble and sink. And she's like, oh my God, he has his heavy hands on her shoulders.
This is a horrifying story.
Yeah. So what she does is that she reaches out, grabs his shirt, twists it, and lowers my huge 6'2" father down on the ground while he passes out, while the needle is still going into her back.
That's crazy.
And so she lowers him to the floor. Like, this is a real mother moment, right? She lowers him to the floor. He quickly gets up. He jumps up, goes, oh, I'm fine. And she goes, stay down. So he just lies there while she finishes her injection. So that's what can happen with the blood and needle phobia.
Oh my God, I'm just imagining that all of the ways that could have gone wrong.
Yeah. Oh, yeah.
So in blood and needle phobia, I mean, are you actually afraid of the needle, or is it like a genetic condition where your body just responds differently than other people? Like, do you have a conscious fear of needles?
That's an interesting question, because it could happen without the fear, right? If I just see a needle, I'm such a chicken. I can't even look when I'm getting a shot or getting blood drawn. So IVF was really horrible.
Yeah.
So it could happen where I'm not even afraid of it if I don't know it's happening, but if I look at it, I pass out or get woozy. Sure. But I guess the association, as we talk about, like the learned fear of it, like I know I'm going to pass out. I'm afraid of my own response to it, so I get anticipatory fear. So technically, no. Technically, I guess it's like this physiological response to it, even if you're not aware that's happening. So
yeah, so you just look a little wimpy every time you have to go to the doctor,
exactly.
And it's not even your fault.
Thank you.
An interesting, I mean, a reason that I do think this is cool is a lot of people have, even if they don't have a phobia, they can be really afraid of their own physical symptoms. So I'll have patients who think that they could pass out at any second, or they're worried about collapsing or embarrassing themselves. It's similar to like people worried about having a panic attack, right? And so this pass out fear, one thing that can actually help to know is that typically when you get anxious, your blood pressure goes up. So it's really just in this blood and needle phobia where it goes down. But if you're one of those people who's really, really worried about passing out, actually what your body is doing is the opposite of that. You're very unlikely to pass out if your blood pressure goes up.
Yeah.
So
no, it's also interesting to think about how all these anxiety disorders are essentially like the same process, right? We have all these different names for them, but it's the same thing. You associate fear with a threat, and then that fear kind of builds on itself for anything else that's associated with it. It kind of latches on, right? I'm afraid of needles, but now I'm also afraid of like when I see a message from my doctor saying you have to go get a shot. I'm like, so, and then I get nervous of my own heart rate and whenever I feel a little woozy, I get afraid of it. So the fear just kind of attaches on to other parts of the experience that are not dangerous, right? Like, There is also another kind of phobia that has gotten a little bit more attention recently. It's called trypophobia. I think that's the way it's pronounced. And basically it's the fear or really intense discomfort of small little holes, like honeycomb patterns or like lotus flowers with a lot of like tiny little holes, right? I think that I read somewhere that this was just kind of brought up in the literature in 2005. It's not an actual phobia according to the DSM quite yet, but it's gotten more traction. There's a lot more people coming out saying, I have that. I'm afraid of holes, especially even the cameras in the back of the new iPhones that have a couple holes. Like some people can't even buy an iPhone because they're afraid of holes. Wow. So that's kind of a new one that's popped up.
Yeah, no, I had to put a trigger warning on my Instagram stories because I was taking pictures of my oyster mushrooms growing and it was that same kind of pattern.
Yeah, that's funny. I mean, we don't know much about it yet. There's some kind of cool research showing that it's a very visual thing, like it's a very specific visual pattern. I think, I don't know the literature on this, but I think the idea is that it looks like some kind of skin disease or other kind of diseases like rashes and things like that. So there might be some kind of biological preparedness in there. But yeah, so we don't know much about it yet, but it's a thing.
One question I would have about that is whether it's primarily a fear response or whether it's primarily a disgust response. Because, I mean, that is so clearly overgeneralized. I mean, it has that same kind of biological framework of there is a reason embedded in us that we would avoid patterns with little tiny holes that remind us of disease or smallpox or something like that. At the same time, fear tells us to like run away quickly, whereas disgust tells us actually like, wait, pay attention to that a little bit while kind of backing away slowly because you want to make sure that it's dangerous and you want to make sure you know what you're dealing with and then get away. So it's just it's a bit of a different emotion. And it'd be interesting to see what the impairments level,
That's interesting. Yeah, the disgust piece is interesting because disgust is really a response that we have to contaminants. So when we have a disgust face, our nose squishes up because you're actually like closing your nostrils so you don't, like it's kind of this, it's not necessarily run away, but it's like don't get contaminated by this. So still a threat, but we just react to it differently. So that's interesting. You got a research study coming. That's a
I
good
think
hypothesis.
We should do it. Yeah. I love disgust. Disgust is one of my favorite topics, so we could do an episode on that. Yeah. So when we think about treating, I mean, do you know if blood and needle phobia is treatable or if it's treated in the same way as other phobias? Because most phobias are treated in the same basic way, right?
I think so. I think all the phobias, the most effective way to treat it is with cognitive behavioral therapies, and specifically exposure therapy. So actually, full disclosure, I don't know the difference in treatment in terms of like outcomes or efficacy with this kind of phobia versus any of the others. But from all I know is that exposure therapy is like the gold standard. So
yeah. And while, all of these phobias are treated in the same way, it is kind of fun to talk about because the lengths that the therapist will go to treat these can be pretty interesting. Yeah. Especially the more creative the phobia.
Yeah. So exposure therapy, I mean, we talked about this before, but exposure therapy is basically gradual exposure. So coming in contact with the thing that you're afraid of, right? It's really effective with actual phobias because there's an object of fear, right? With generalized anxiety, you're afraid of everything. So it's kind of hard to know what to get yourself in contact with. But this is like, here's the spider, the needle, you're afraid of that, right? So, and it's gradual where it's like at first you might imagine the actual object, like I close my eyes and think of a spider or think of a needle or getting my blood drawn. And then I slowly, build up to maybe then I'll touch the needle or maybe I'll look at a video of it on YouTube or maybe I'll look at someone else and then I work myself up to the full thing that I'm afraid of. So yeah, it's being an exposure therapist is really interesting because it's just basically like making someone confront their fear over and over again in brutal ways, like really really, it's more effective. Your job is to scare the patient, right? But walk them through it gradually. So it's an interesting job.
Well, that was quite an advertisement for therapy.
Yeah. Super effective. So,
So I've done exposure in the context of the unified protocol. In that treatment, which I think is also effective for phobias, so unified protocol is this treatment that is meant for emotional disorders broadly. So it's not right for instance, psychotic disorders. And I wouldn't use it for something like borderline personality because there's a much more effective treatment there. But in terms of just sort of broad level, like anxiety disorders, the UP is pretty good. And in the UP, we spend the first module kind of talking about emotions and why they make sense, figuring out how the patient experiences those emotions. And then we teach a number of skills that build up to the exposures at the end. So we'll teach mindfulness skills, and then we'll do cognitive flexibility, and then we'll do a physical module, so getting comfortable with body sensations. And then we'll do alternative actions, or basically behavioral modification. And then all of this culminates in this exposure where we talk about it with the patient. What do you think it would be a challenge for you, but it's not so extreme that, you're going to not come into therapy, basically. So we get an appropriate level of difficulty, and then the next 2 sessions, we might increase that difficulty each time, or maybe do the exposure in a different way, in a different context. And basically what we try to do is, instead of, if you have somebody who's terrified of spiders and then you put a spider on their head, like I was suggesting to do to Kibby, their phobia can get worse because they're just going to be shocked by that. And it's going to reiterate how terrifying this is. But in the UP, the way you do exposure is, it's much more intentional. They understand what's happening. They have a chance to use the skills that you've been spending the whole treatment developing. And then when the phobic, let's say when the spider is there, they're actively using their skills. And then afterwards, you kind of debrief. You say, what did you wind up thinking, feeling, behaving? What actions did you take? Did you try to avoid the situation? How could you lean in more next time? And often what they'll say is, that was really horrible, but I feel really accomplished. I feel proud of myself. I've realized that I didn't die in contact with a spider. I was able to handle it. And then you increase the difficulty level. But there is another kind of exposure that you're talking about, right? Where it's this longer term treatment that starts really, really small. Like, here's a picture of a spider. Here's a stuffed animal of a spider.
Yeah. I mean, what we're talking about is, and when we say exposure therapy, mm-hmm. that's actually woven into a bigger treatment package, like you're talking about Unified Protocol. Unified mm-hmm. Protocol uses exposure interventions. Right. And exposure is like the process of coming into contact with things that you're afraid of and learning that they're not actually dangerous or that you can cope with it, right? So mm-hmm. we might sound like we're talking about very different things, but the Unified Protocol is just almost like a school curriculum. It's like a class curriculum for how to conquer your anxiety, and it has like the class in the curriculum, which is like exposure therapy. So if exposure therapy, if you're really just treating phobias, right, in Unified Protocol or something else, you might not want to jump right to putting a spider on my face, because then I would drop out. Then I would leave your office and never come back, right? Mm-hmm. But if you say, okay, we're going to slowly work up to you getting more comfortable being in front of and getting in contact with this thing that you're afraid of, spiders or needles, and doing it in a way that you feel like you can do it, right? Like, if I don't feel like you could put a spider on my face, but sure, I could look at a plastic spider mm-hmm. and start there. And then, and the way it actually is supposed to work is what's called, it's called emotional processing. And habituation. So these processes of change, as they say, is when I come in contact with, let's say, the first step, a plastic spider, my phobia, my fear response is going to say, oh, I'm going to die. This is so scary. I'm under threat. But when I touch the plastic spider over and over again, I'm going to eventually learn, I didn't die, as you said, right? That's emotional processing. I've learned through my experience with this that it's not actually dangerous, or it's not as dangerous as I thought. And then I will habituate. So my fear response will go up, and then it goes down. And then I see that over and over until actually the fear responses kind of die down, and I start to get kind of bored. I'm like, okay, this plastic spider, big deal. I'm bored. Let's move on to the next stage, right? And so then you kind of work yourself up. So that's exposure therapies are woven into all different kinds of CBTs, like Unified Protocol, but that's the basic principle. It's like exposing yourself to the threat over and over again in gradual steps until you learn that it's not as dangerous as like your amygdala, your like fear response will want to tell you. Because it's acting like you're going to die, right? Your heart rate's going up, you want to run away, but it's a plastic spider, so that response doesn't make sense. So you're just learning over time what's the appropriate response.
So as I said, therapists will go to pretty interesting lengths to treat phobias with patients. I know of one psychologist up in Boston who helps people with, among other phobias, flight phobias. And so he will work himself up to actually taking a flight with his patient. And so he will start in Boston, fly to New York, and then they'll turn right around and fly back. And there's actually a kind of a funny addendum to this story where he does this so many times, he kind of caught like TSA's eye. They're like, why is this guy taking all these really short flights back and forth in like a single day? And he was taken to security or something, and he had to explain like, no, I'm a psychologist. They're like, we don't believe you. So so it can go in interesting directions. We had our former postdoc, Claire Robbins, would, if people, this is more for social phobia, so social anxiety, but if people were really, really afraid of being embarrassed, one thing she did was make them go on a walk around town with a banana on a string. So like walking the banana like they would walk a dog. So just like make them do totally ridiculous things. Because if you can get through that, you can probably get through less embarrassing, like more reasonably embarrassing situations.
Yeah, I had a friend who was specialized in exposure therapy for phobias, and he was saying he loved it because it taught him as a therapist to be super brave. Mm-hmm. Because what you're doing is you're trying to make the patient come in contact with something they're terrified of, and you have to model that this is okay. It's not dangerous, and if it is, we can cope with it, right? So you have to be kind of stoic and be like, okay, we're going to do this. We're not going to avoid. That's a huge job of the therapist, is not to let them avoid, not to, like try to calm them down or try to, sugarcoat anything. It's like, nope, here you are. We're getting on the plane. It's scary. Let's do this. My friend said that he was treating claustrophobia, the fear of small spaces. And so in his clinic, there is this closet with a padlock on the front that it's about the size of a coffin. And they would stick the patients in there, lock it up, and the patient would be screaming and cursing. Wow. And he would just say, all right, you're going to be in here for, X number of minutes or whatever their exposure was. And yet that's how they treated claustrophobia.
Oof. Mm-hmm. Yeah, that one would be tough to have to hear my patient screaming. I mean, I've done misophonia exposures, and again, misophonia is not a phobia, but it's just the same principle. I mean, I've just sat there and ate strawberries in front of my patient for a while, because that was a particularly gross sound to them. And then another time I wanted to eat while having the sniffles, so I ate a hot chili pepper so that I would be just like, my sinuses would be wiped out, and I'm just like, crunching at the same time. So so exposure work is fun.
Yeah, it's fun. It's actually, it should be fun for both parties, right? This is scary, of course, for patients, but it's a really different kind of therapy than we're probably used to, like sitting and talking. It's just very active. It could be very funny because you're doing crazy stuff like eating strawberries in front of somebody, but it's super effective. And so it's just kind of an example of how CBT's really mastered a disorder. Yeah. Thinking about other things that therapists will do for exposure therapy, when I was looking at the literature in preparation for this episode, There's a lot of stuff coming out about virtual reality. So I only heard a little bit about this through exposure therapy phobia clinics. But now I'm seeing that it is like catching like wildfire because probably virtual reality and augmentative reality are getting just more advanced and more available. Mm-hmm. So what's cool is that if a person like really cannot, if they're so severe that they can't even be in contact with anything remotely close to a spider or a snake or a flight, or they just don't have access to it, right? Like getting on a plane could be like expensive and hard for some people. So how are you going to do exposure to something like that? Well, a lot of different treatments and clinics are now looking at using virtual reality to have like some kind of way that the person is exposed to and comes and sees and comes in contact or interacts with the phobic object, right? So like a virtual reality room or a headset where they look like they're on a plane, right? I heard some clinics have that. And it's just a really cool way of integrating. We always talk about how technology and digital mental health are really exploding now, are really becoming more and more advanced and used in therapies. And this is one way where technology is really helpful for treatment. So instead of having to put a bunch of people on planes, you can have them come to your office, do a virtual reality or augmented reality game, and do the exposures that way. I think it's really cool.
Yeah, it is much more realistic because it is hard to imagine having 8 patients a day, and then with one patient, you need to be on the top of a skyscraper, like within that one session. So if we have friends or loved ones who have phobias, I mean, I guess my first suggestion, besides encouraging them to seek exposure treatments within CBTs, would be to bolster their sense of agency. So if they are doing things like bringing safety objects, maybe even just to reinforce, like, your socks didn't get you through this flight, right? That was you. You got yourself there. You managed your stress. Anything else or anything you would add to that?
Yeah, it's the same principles as we talked about before. There might be some ways where people, like loved ones of someone with a phobia, can actually accidentally reinforce and maintain the phobia by helping that person avoid it. So the problem with avoidance with anxiety disorders is that you are not in contact with the thing you're afraid of. So you don't have the opportunity to learn over time that you actually are safe or can cope with it. So it actually, avoiding situations maintains the phobia. So people who are just trying to be helpful and trying to support their loved one, they might drive them everywhere they want to go, or they might, make sure there's no spiders in the area, or be okay with them that they don't go for doctor's appointments where they might need a shot, and that might actually be have long-term consequences for their life, right? So I would say not reinforcing the avoidance behavior, but helping them, as you say, feel like, okay, I can come into contact with this and I don't need anything to keep me safe. I just know that thing is not as dangerous as my body thinks it is, and then over time I'll learn that I can actually get better. So I think a lot of family members and friends are involved with exposure therapy, like helping that person expose themselves to those situations out in their life and take away their safety behavior. So so as friends and other loved ones, don't necessarily help that person avoid those things. I know that in the short term that might be just get you through their day. But in the long term, that's actually, worse for the phobia.
Yeah. And I know it might, if you do have a phobia, it might sound overwhelming listening to this and realizing what the therapy entails. But I think patients really commonly report feeling very proud of themselves, feeling like really an enhanced sense of agency. And just remember that as you're maintaining this phobia, what you're telling yourself by avoiding is the only way I keep myself safe is by restructuring my life. The only way I keep myself safe is by avoiding everything that's possibly dangerous. I can't get through this. I can't handle this. And really what the therapy does is it breaks down all of those beliefs. You can handle this. You can get through this. Your body can do a lot more than you think it can. You can do a lot more than you think you can. So even if something is embarrassing or a little scary, you can get through the day, and your relationships will be fine, and your image will be fine. So really, I think this is one therapy that is immensely rewarding over time.
And also think about what you would gain in your life if you're able to overcome this phobia. This is with any kind of therapy. I mean, sure, you are afraid of flying, so you don't go anywhere that requires a plane flight. But what are you holding yourself back from? Are you holding yourself back from a job that's your dream job? Seeing family members across the country? If you're afraid of germs or dirt or spiders or insects, are you unable to bring your kids to the playground? Things like that, where just having a clear idea of what you will actually gain and get back in your life if you overcome this phobia, that's super, super helpful for getting people through like a really kind of intense kind of therapy, right? You're asking people to get scared on purpose. Yeah. So knowing the why is just really helpful.
Okay, well, on that hopeful note, Kibby, do you have any resources?
Yeah, the Treatments That Work series, as always, is one of my favorites. There is a manual called Mastering Your Fears and Phobias by Michelle Krask. Michelle Krask is a professor at UCLA. She's super famous and super wonderful. She's well known for treatment of anxiety disorders. So you could get that on Amazon. And you could work through that yourself, or you could use that with a therapist or with a loved one too. So I'll put that on the website and you could go check it out.
Awesome. And don't be scared to rate, review, and subscribe to Little Help for Our Friends. Thank you all, and we'll see you next week. By accessing this podcast, I acknowledge that the hosts of this podcast make no warranty, guarantee, or representation as to the accuracy or sufficiency of the information featured in this podcast. The information, opinions, and recommendations presented in this podcast are for general information only, and any reliance on the information provided in this podcast is done at your own risk. This podcast and any and all content or services available on or through this podcast are provided for general, non-commercial informational purposes only and do not constitute the practice of medical or any other professional judgment, advice, diagnosis, or treatment, and should not be considered or used as a substitute for the independent professional judgment, advice, diagnosis, or treatment of a duly licensed and qualified healthcare provider. In case of a medical emergency, you should immediately call 911. The hosts do not endorse, approve, recommend, or certify any information, product, process, service, or organization presented or mentioned in this podcast, and information from this podcast should not be referenced in any way to imply such approval or endorsement.